Now comes another part of operative dentistry, which is the treatment of primary anterior teeth. Now, rampant caries and nursing bottle caries and even tooth crowding are responsible for the caries in primary anterior teeth. This may lead to severely mutilated teeth or minor or incipient caries in the anterior teeth. Now, how is such type of caries treated? In the case of class 3 anterior restorations, when the caries involve the proximal surface of the anterior teeth without involving the incisal edge or the incisal angle. If the caries are incipient in nature or minor caries are there in the primary anterior teeth, then we generally go for enameloplasty. That is, we reorder and reshape the enamel, or the recontouring of enamel is done by the burr, and then topical fluoride is applied for prevention of further demineralization. But if the caries process is more advanced or there is demineralization or undermining of the enamel, then we go for proper cavity preparation. Now in the cases of maxillary anterior teeth, we go for a dovetail preparation lingually. But in the case of mandibular anterior teeth, the dovetail is prepared labially due to aesthetic reasons simply. So the caries excavation is done, then a proper dovetail in the shape of a U is prepared on the labial or the lingual or the palatal surfaces of the teeth, and extensive or additional retention is provided by the gingival or the lingual locks in this dovetail. Here we can see in the figures that the dovetail is prepared and the slot is prepared for additional retention. If there is a gingival undermining, then we go for a gingival extension also, and it is kept in mind that the gingival seat is inclined at 90 degrees to the axis of the teeth. In the case of a mesodistal decay, we again go for recontouring and shaping of the gingival line, and a proper proximal boss is prepared proximally. In the cases of the primary canine, if the modified class C preparation is done, a dovetail is prepared on the lingual surface or the labial surface, for example in the maxilla or the mandible, and again a gingival groove is given and the dovetail is placed. Then after preparation of the cavity, if the cavity is deep, then we place a cavity liner, for example calcium hydroxide. We can etch the enamel and the margins of the cavity for proper retention by the means of 37% phosphoric acid, that is hypophosphoric acid, for a time of 2 minutes. Then after 10 seconds of rinsing of the hypophosphoric acid, then we go for bonding and placement of the composite restoration or glass ionomer cement without these bonding procedures. We even place for a proximal support a myelin strip so that the proper contouring of the restoration takes place, and final finishing is done by the means of finishing burrs. In the case when the incisal edge or angle is involved, in the case of class 5 preparations, 330 number burr is used for undermining and removing all the undermined enamel. Then the dentine and the pulpal wall is generally prepared, which is convex because the pulpal size is also convex. Shape and contour of the pulpal cavity is convex. Then mechanical retention grooves to the undercuts are given at the gingival level and the inciso-axial line angle. Then the resin-based composites are cured in the cavity. Etching, bonding and placement of the composite resin restoration is done, and final finishing and polishing of the restoration is done by the means of finishing burrs. Now, what is basically a sandwich technique? In the sandwich technique, the exterior of the cavity is occupied by the glass ionomer restoration, and interior or beneath the glass ionomer restoration, a composite is done, or composite filling is done. This is basically in the cases of extensive cavity, or this is even a better technique for retention of the restorative material. For in order to attain both the beneficiary properties of the glass ionomer cement, that is the anti-carious property, and the composite restoration, the aesthetics and the other features also. So the bonding of the resin composite to dentine with an intermediate layer of glass ionomer cement. The glass ionomer cement will be in contact with the tooth surface, and the fluoride etching and the anti-carious measures taken by the glass ionomer cement will be beneficial to the tooth by this sandwich technique. There is an open technique and the closed technique. In the open technique, the cavity is open, the composite occupies the outer layer, the glass ionomer is beneath the composite, and in the closed cavity, the cavity can be attained by the means of tunnel preparation. Now comes the full coverage restorations, which basically belong to the strip crowns, the polycarbonate crowns, the art glass crowns, etc. These are done in the case of a large restorations when the proximal lesions are larger, when they cannot be restored by normal cements. In the case of pulp therapy, we go for such type of crowns. In hypoplastic teeth, or in the case of severe levels of fluorosis, in the case of discolored teeth, when in small interproximal lesions are not easily demonstrated, or in the case of large cervical decalcifications. Then full coverage restoration basically involve the resin or the strip crowns, the stainless steel crowns, the resin or vernier stainless steel crowns, the polycarbonate crowns, and the art glass crowns. Now, what is the basic procedure for undertaking such full coverage restorations? First of all, we'll do administer local anesthesia to the teeth, then proper rubber dam placement is done, then selection of the crown is done, and cutting of removing of any carious lesion from the tooth, and the crown selection, the crown placement, the cementation, and the removal of the excess cement, and finishing and polishing is the final step. Now let us come to the strip crowns. Strip crowns are aesthetic crowns which are used in the anterior teeth in the case of severely mutilated teeth, the hypoplastic teeth, the discolored teeth in the cases of amelogenesis imperfecta, or in the case of pulpectomizes teeth. In the case of strip crown, first we'll take all the basic procedures like rubber dam application, local anesthesia administration, retraction by the means of cords. Then the strip crown or the crown of the tooth is measured, or the contralateral tooth is measured for fitting of the strip crown size. Then the reduction of the tooth will be done labially or lingually and incisively with a slow speed burr, which is 0.5 to 1 millimeter proximally and 1.5 mm labially if the tooth is larger in size. Then we'll go for measuring the crown, and the approximate size of the crown is matched with the tooth. After matching the crown size, the placement of the trine is done. The excess of the cervical line of the strip crown is cut by the means of crown cutting scissors, and a vent is created on the mesodistal angle of the strip crown for escaping of any excess composite material. Then the composite material or the glass ionomer cement is filled in the strip crown, and the crown is tried on the tooth. After trying the crown of the tooth, the crown is cured by the means of a composite light, and finally it is scraped out from the tooth structure, and the crown is finished and polished. And the excess cement will flow out from the crown vent which was created additionally. Then comes the art glass crowns. These are basically polymers of methacrylate forming a cross-linked structure. This is a dimensional polymer. It is available in one shape and 6 sizes. Then how do we restore a primary molar? The primary molar is restored by the means of a preventive restoration, the class 1 cavity preparation and then restoration of the cavity, then the class 2 cavity preparation and restoration. Now, preventive resin restoration is a preventive technique for the basically pit and fissure caries. Here, all the fissures are involved and cavity preparation is done in the fissures. Then, by the means of the etching hypophosphoric acid, they are etched for 30 seconds. Then further, they are washed out, then dried, and the preventive resin restoration is applied to these fissures, and finally, it is cured. The occlusal adjustment is done by the means of a burr, and layer by layer polymerization of the composite resin is done in the pit and fissure sealant cavity. Now, in the case of class 1 cavity, what are the basic features or factors for the class 1 cavity? First of all, the depth of the cavity should be kept in mind because the primary dentine is less thicker than that of the permanent teeth. So, the depth of the cavity should be just 0.5 mm to 1 mm into the dentine, and the total size or depth of the cavity should be about 1.5 mm. All the rind angles and the point angles should be rounded to prevent any excess stress on the tooth and the restorative material so that it does not breaks out or the tooth does not cracks out. Then this is the resistance form of the tooth. Then the line angles and the point angles should be rounded. The axiopulpal line angle should be rounded or beveled. Then the pulpal floor should be concave because the pulpal cavity is also concave in size and structure, and also to release any stresses. The cavo surface angle should be 90 degree. And finally, in the case of class 2 cavity, the proximal box should be wider than that of the class 1 cavity. The proximal box in the permanent teeth is much narrower than the proximal box in the primary teeth. And it should extend up to the self-cleansing areas. It should always be above the contact point, and the gingival wall should be straight. It should not be beveled because the enamel rods, they are tilted occlusally in the primary teeth. The axial wall should be in contour with that of the wall of the tooth, and the proximal box should be placed beneath the contact point. Then these cavities can be filled by the means of the glass enamel restoration or the composite restoration. The following steps are there with the etching, then the washing, the curing and bonding of the resin, and finally the polishing. There are certain modifications of the cavity in the case of proximal lesions. When the proximal lesion is 2.5 mm below the marginal ridge, then what we do? We directly approach the cavity or the caries without affecting or undermining the marginal ridge. This is known as a tunnel preparation. Here, the burr is moved directly from the lingual pit or the buccal pit into the proximal lesion, and obliquely the burr is moved. Like buccal and lingual movements are done till the caries process is reached, and after that final cavity preparation, restoration of composite or GIC is done accordingly. The contraindications of such lesion or such tunnel preparation is in the case of large carious lesion or large proximal caries. They are generally indicated on only small lesions. So here we have seen the various restorative procedures and the restorative materials which are used in the primary anterior teeth in the case of operative dentistry, which is related to pedodontics. Thank you.